Bismillahirrahmanirrahim. Today we will discuss drugs during pregnancy. Drugs used during pregnancy is important to clinicians because of the potential adverse effect on the embryo, fetus, and newborn. We will discuss today factors affecting transfer of drugs to the fetus, what is teratogenicity, what is principles of teratogenesis, what are the adverse effects of some drugs on the fetus during the later stages of pregnancy, what is the FDA pregnancy risk categories classifications, and lastly, the risk communication prior to pharmacotherapeutic choice. We must know the teratogenic potential of the drug and the critical periods of the exposure and the magnitude of the risk to avoid occurrence of teratogenicity. This is case scenario for a woman at 8 weeks of pregnancy, and she takes some medication for some diseases, and now she get pregnant, and she asking the doctor for the use of her medication during pregnancy and the possibility of occurrence of birth defects. So we must know the teratogenic potentials of any drugs used during pregnancy and the critical periods of exposure. What is the time of drug exposure? Is it in the first trimester, second trimester, or third trimester? And the magnitude of the risk that may occur to the fetus to avoid occurrence of this teratogenicity. The term teratogenic is used to denote an agent that has the potential under certain exposure conditions to produce abnormal development in the fetus. Thalidomide, which is a drug used to treat pregnancy-related nausea and vomiting, which is common during pregnancy, was discovered that cause severe anatomical birth defects in infants of mothers who took this drug in early pregnancy. So thalidomide was the first drug discovered as a teratogenic drug. So it is important to know what are the factors that affect the transfer of the drugs from the mother to the fetus. You know that placenta, passage of drugs through the placenta occurring by diffusion. Diffusion across the placenta is the main mechanism of drug transfer from the mother to the fetus. So what are the factors affecting the transfer of drugs to the fetus? Number one is molecular weight of the drug. Large molecular weight drugs don't cross the placenta. This is like insulin and heparin. So if the drug has the large molecular weight, it will not cross the placenta, which is better for the fetus. But unfortunately, most of the drugs, their molecular weight is smaller than 600, which can pass through the placenta. So most of the drugs can cross through the placenta and reach the fetus. This is the first factor, which is the molecular weight of the drug. The second one is lipid solubility and ionization of the drug. You know that non-ionized drugs or non-ionized substances are lipophilic and can cross easily through membranes. So it is transferred rapidly through the placenta. Non-ionized lipophilic substances are transferred rapidly through the placenta. But ionized substance, which is less lipid soluble, so it cannot cross through the membrane, so it crosses the placenta very slowly. Again, the drugs that are ionized at the physiological pH cross slowly, but the drugs which are most of the weak acids and weak bases with pKa between 4 to 8 will transport it to the fetus and transported through the placenta rapidly. So, lipid soluble drugs can cross the placenta. However, weakly basic drugs may become trapped in the fetal circulation, which is called ion trapping, producing a prolonged effect of the drug in the fetal compartments. Ion trapping occurs because the fetal plasma pH is more acidic than the maternal plasma pH, causing the weak bases to become ionized and more disionization occurring due to more acidic fetal blood. So it will produce condition called ion trapping. The drug will be trapped in the fetal circulation due to more acidic pH of the fetal blood. So it will produce harmful and prolonged effects to the fetus. The third factors affecting the transfer of drugs to the fetus is protein binding. Highly bound protein drugs don't cross the placenta. Only the free unbound drug can cross the placenta. What are the factors affecting the level of unbound drug fractions in the fetus? Due to increased maternal unbound drug fraction. Again, the unbound drug only passes to the placenta. The highly bound drugs cannot cross the placenta. What are the factors affecting increased maternal unbound drug fractions? It is due to decreased plasma albumin concentration during pregnancy. You know that during pregnancy there is some physiological changes occurring to the circulation of the mother, affecting the kinetics of the drugs taken by the mother. From these changes, there is dilution, there is increased plasma volume, leading to dilution of the plasma albumin with decreasing their level. So it will increase the maternal free concentration of the drug. Again, during pregnancy, there is increased plasma level leading to decrease of the plasma albumin. So the drug which are usually has affinity to the plasma protein will increased their free concentrations. So the plasma protein binding is an important factor affecting the transfer of drugs to the fetus. Also, the uterine blood flow can affect the rate of drug transfer to the fetus. So what are the variables that can affect uterine blood flow? Number 1 is maternal blood pressure. If there is maternal hypotension, it will reduce the uterine blood flow and the rate at which the substance reaching to the fetus through the placenta. Number 2 is cord compression. There is mechanical pressure on the cord, reducing the blood flow to the fetal sides of the placenta. Also, the drug therapy like alpha stimulants, like epinephrine or any alpha stimulants, may constrict, causing vasoconstriction of the uterine blood vessels, leading to reduction of the blood flow. So, any factors that can reduce the uterine or umbilical blood flow can affect or can reduce the amount of the drug reaching to the fetus through the placenta. Also, if there is any maternal diseases like pregnancy-induced hypertension or diabetes, also these diseases can affect the permeability of the placenta, either increasing the passage of some drugs or decreasing the passage of another. So the maternal diseases can affect the transfer of drugs through the placenta. So the factors are molecular weight of the drugs, lipid solubility and ionization, protein binding, and any factors affecting the uterine blood flow to the fetus. These figures show the drug depositions in maternal fetal placental system. Number 1, they can summarize the factors affecting the transfer of drugs to the fetus. Number 1 is altered maternal absorption. Number 2 is, as we have said, increased maternal free drug fraction. Increased maternal free drug fraction or maternal unbound drug fractions. Number 3 is the increased maternal plasma volume, also affecting the transfer of drugs, especially drugs which has high affinity for plasma protein binding. Number 4 is altered hepatic clearance of the mother due to physiological changes occurring during pregnancy. Number 5 is increased maternal renal blood flow, also affect the elimination of the drug in the mother. Number 6 is the placental transfer, either metabolism occurring during the placenta, which is number 7, or the placental blood flow, which is number 8, or the pH differences between the fetus and the mother, which is number 9, and the bypass of some or about half of the fetal blood circulation that bypass the liver of the fetus and reaching directly to the heart and brain of the fetus, which is number 10. Also, number 11, the drug can pass to the brain of the fetus because there is underdevelopment of the blood-brain barrier of the fetus. Number 12, immature fetal liver enzymes activity. Number 13 is increased fetal unbound drug fraction. Again, alterations in the pharmacokinetics of drugs are influenced by mainly two factors. Number 1 is maternal physiological changes that occurs during pregnancy. Number 2, the effects of the placental fetal compartments. To summarize this figure, maternal and fetal drug concentrations are dependent on three factors. Number 1, the amount of drug that crosses the placenta. Number 2, the extent of metabolism by the placenta itself. Number 3, the fetal distribution and elimination of the drug. Now, what is teratogenicity? Teratogenicity is used to any agents that has the potential under certain exposure conditions to produce abnormal development in the fetus. So we can define teratogen as any agents that results in structural, number 1, or number 2, functional abnormalities in the fetus or in the child after birth. These abnormalities that occurring in the fetus or the child after birth are the consequence of the maternal exposure of drug during pregnancy. So it is an agent that results in structural or functional abnormalities in the fetus or in the child after birth due to maternal exposure of a drug during pregnancy. The mechanism of teratogenic drug may be due to direct effects of the drug on the fetus or as a consequence of indirect physiological changes that occur in the mother or in the fetus. What are the manifestations of congenital anomalies? The congenital anomalies are non-reversible birth defects. It is non-reversible. The drug-induced effects may be related to changes in the functions or in conditions that are not structural abnormalities. It may be mental retardation, it may be central nervous system depression, it may be deafness, it may be tumors, it may be biochemical changes. So we can classify the congenital anomalies into 4 manifestations of abnormal fetal development. Number 1 is alteration in the growth. Number 2 is affection of the function. Number 3 is obvious structural malformation. Number 4 is fetal deaths. Congenital anomalies may be obvious at birth or delayed many years after birth. May be obvious at birth in the form of any limb abnormalities, spina bifida, hydrocephalus, according to the drug administered to the mother. Or it may be delayed many years after birth. It may appear in the form of behavioral and intellectual disorders. This occur in childs in which their mother taking alcohol during pregnancy. Mother drinking alcohol during pregnancy will lead to behavioral and intellectual disorders of her children. Also, mothers taking diethylstilbestrol during pregnancy may have a daughter having vaginal cancers many years after birth. During adolescence period of the daughter may have a vaginal cancer due to the previous history of taking diethylstilbestrol by her mother. So the congenital anomalies may appear at birth or it may be delayed many years to be manifest clinically. Now, what are the principles of teratogenesis? First, we will discuss the factors affecting the extent to which the drug will affect the development of the fetus. Like number one, physical and chemical properties of the drug. As we have said, that physical chemical properties of the drugs like molecular weight, lipid solubility and ionization of the drug, protein binding, and any factors affecting the blood flow to the fetus. All will affect the amount of the drug reaching to the fetus. Number two is the dose and the duration of the drug. All teratogens have a threshold dose below which the adverse effect will not occur. Also, as we have said, the maternal and fetal drug concentrations depend on the amount of the drug crosses to the placenta. So, according to the dose, it will be the amount of the drug reaching to the placenta according to the other factors we have mentioned. Also, the extent of the metabolism of the drug by the placenta also affect the amount of the drug reaching to the fetus. And also the fetal distribution of the drugs will affect the concentration of the fetal free drug. So the dose can affect or can determine the extent of the drug effects on the development of the fetus. The teratogenic potential of some drugs is influenced by the genotype of both mother and the fetus. as the same dose of the teratogenic agent exposed at the same gestational time will produce variable results in different people according to the genotype of each one. This genetic variability can affect the cell sensitivity, placental transporter of the drug metabolism, and the receptor binding, which may all affect how much active drug will reach to the fetal tissues. So there is genetic variability according to the drug can affect the fetus. So not all fetuses exposed to the known teratogenic drugs show evidence of having been affected in utero. May not be affected. Again, the factors determining the extent of the drug's effects on the development of the fetus: number 1, physicochemical properties of the drug. Number 2, the dose of the drug. So you must use the lowest effective dose in pregnancy. Number 3, the genetic fetal predisposition. Number 4 is the biological susceptibility of the mother. Also, the timing of the exposure of the drug can determine the occurrence and severity or the nature of any adverse effect on the fetus. So the stage of pregnancy at which the drug is administered can determine the occurrence of any adverse effects to the fetus. For example, folic acid antagonists like trimethoprim are associated with an increased risk of neural tube defect if the exposure occurs 3 to 4 weeks post-conception, but not after this period. However, it must be avoided after the 32 weeks of gestation, at late pregnancy in the last trimester, because of risk of severe jaundice of the neonate. Very few drugs are in fact proven a teratogen, and exposure in the second and third trimester may still result in fetal harm. Usually, the fetal harm, as we will discuss later, occurring especially in the first trimester. But some drugs which are proven as a teratogen can also causing harm to the fetus either in the first trimester, second trimester, or third trimester. These drugs, like as in the table, number 1 is phenytoin. Phenytoin is an anti-epileptic drug that used to the female if the female is epileptic and get pregnant and she or her medication is phenytoin. If they continue using phenytoin during pregnancy, it will lead to fetal hydantoin syndrome, which is in the form of, it is a congenital anomaly, a structural anomaly, structural and functional anomaly in the form of cleft lip or palate, as in the picture, microcephaly, which is a small head, and it is associated with mental retardation. This is the congenital anomalies of the phenytoin. It may occur if the drug is given at any stage of pregnancy, especially the first trimester. Number 2 is lithium. Lithium is a mood stabilizing drug used in treatment of bipolar depression or mania. If it is given during pregnancy, it will lead to Epstein anomaly. This Epstein anomaly is a heart defect that affects the tricuspid valve between the right atrium and right ventricle. In the anomaly, the valve doesn't work properly, it cannot close completely. There is tricuspid regurg. So, the blood will flow back into the right atrium. This is the Epstein anomaly. Valproic acid and carbamazepine are anti-epileptic drugs. If given to a pregnant female with epilepsy, it will lead to neural tube defects in the fetus. It may be in the form of spina bifida, like exposure of the spinal nerve due to neural tube defects. Also, trimethoprim can lead to neural tube defects. We are discussing the drug considered to be proven as human teratogen. The drug cyclophosphamide, which is cancer chemotherapy, can cause limb defects or intrauterine growth retardation and neurobehavioral deficits. Also, the non-steroidal anti-inflammatory drugs cause constriction of ductus arteriosus, as we will discuss later, or oral clefts, and cardiac defects may be occurred if given to the pregnant female, especially in the first trimester. Angiotensin converting enzyme inhibitors is from drugs considered to be proven human teratogen. It causes pulmonary hypoplasia. Also in the picture you see the cleft lip and the palate. This congenital anomaly can be caused by corticosteroids, if these corticosteroids are used to the pregnant female. Again, warfarin also is considered as a proven human teratogen. It will cause fetal warfarin syndrome with depressed nasal bridge and hypoplasia of the nose, as you see in the picture. There is hypoplasia of the nose. Also, vitamin A or retinoic acids, when given to a female, usually this drug is commonly given to female for treatment of acne. If this female get pregnant, this vitamin A can lead to microtia, which is under development of the ear pinna, as you have seen in the picture. Or it may lead to complete absence of the ear, which is called anotia. This is congenital anomalies will be occurred due to vitamin A given to a female and get pregnant. It will lead also to thymic aplasia and cardiovascular defects. Also, some anti-thyroid drugs will lead to neonatal goiter, so it must be avoided during pregnancy. Also, as we have said, the diethylstilbestrol may lead to vaginal carcinoma in young females if their mothers is with history of taking diethylstilbestrol during her pregnancy. As we have said that the time of exposure of the drug to a pregnant female is very important. So, the human gestational period is divided into 3 stages. At first, the human gestational period is about 40 weeks from the first day of the last menstrual period and 38 weeks after fertilization. After fertilization, the development of the embryo and fetus is divided into 3 main stages. These are the early human fetal development, which is pre-embryonic and embryonic stage. After fertilization, the development of the embryo and the fetus is divided into 3 main stages. Number 1 is pre-embryonic stage, which is the stage of fertilization and implantation. It is from day 0 to 14 days. The drugs in this stage lead to death of the fetus at very early or subclinical stages. It may regenerate completely after exposure if the exposure is to a sublethal dose. So, exposure to a teratogenic agent during this period will produce all or none effect on the ovum. The ovum either die from exposure to a lethal dose of a teratogenic drug, or it may regenerate completely after exposure to a sublethal dose. So, it is all or none effects. Stage number 2, which is embryonic stage or organogenesis period, which ranges from 14 days to 56 days. It is the most sensitive period to teratogenic effects. So it represents the greatest risk of the major birth defects. So women must advise to avoid or minimize all drugs used in this period of the first trimester. This is the first trimester. The third stage is the fetal stage or stage of growth and development period, which occur after day 56 or weeks 9 to 38 after fertilization. You can measure the period either from the first day of the last menstrual cycle or from the date of fertilization or ovulation. The third stage, as we have said, the stage of growth and development, at which the fetus remains susceptible to some drug effects. As we will mention later, there is some adverse effects to some drugs when given in the later stages of pregnancy, which is the fetal stage. This is table show the adverse effects of some drugs occurring during the later stages of pregnancy. As you have seen in the picture, there is a floppy infant syndrome. This is due to benzodiazepines. Benzodiazepine drug is a sedative hypnotic drug, may be given to the pregnant female. It will lead to, it has a skeletal muscle relaxant effect. It will lead to hypotonia and decreased muscle tone all over the body of the fetus, and it will lead to what we call floppy infant syndrome. This is the benzodiazepine if given in the fetal stage at the later months of the pregnancy. Also, ACE inhibitors, as it is considered as a proven teratogene when given in the first trimester. Also, in the last trimester, it may lead to fetal hypoxia, hypotension, and fetal kidney anuria. So we are studied these drugs under a proven human teratogens. Also, it is important to know that tetracycline, which is antibiotic commonly used during pregnancy. Any females may have a UTI infection or any infection during pregnancy, and we are studied these drugs under a proven human teratogens. Also, it is important to know that tetracycline, which is if the woman is given tetracycline at later stages of pregnancy during the fetal stage, it may lead to permanent discoloration of the deciduous teeth of her child after birth. And also non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, or any non-steroidals may lead to premature closure of the patent ductus arteriosus. You know that ductus arteriosus is a fetal blood vessels. As you see in the picture, in the circle in the picture, it is normally closes soon after birth. The presence of ductus arteriosus in the fetal circulation allow right to left shunting of the oxygenated blood from the placenta to the fetal systemic circulation, so bypassing the fetal pulmonary circle. In the fetus, the ductus arteriosus is kept open until birth. It is kept open in the fetus by the placental prostaglandin E2. So, use of non-steroidal anti-inflammatory drug to the mother will lead to inhibition of the formation of the prostaglandin E2, so it will lead to premature closure of the ductus arteriosus. So the premature closure of ductus arteriosus is due to inhibition of the placental prostaglandins by non-steroidal anti-inflammatory drug. Now, there is food and drug pregnancy risk category classification. Food and Drug Administration introduced a system of rating pregnancy risks associated with pharmacological agents. This system categorizes all drugs into one of 5 pregnancy risk categories, either A category, B category, C category, D category, or X category. It establishes the level of risks to the fetus based on animal and human data and recommends the degree of caution that should be undertaken with each drug. The category A, there is controlled studies in human and no risk. So any drug under this category is safe, can be given to the pregnant female. The category is based on animal study and human study and establishment of the risk. So category A, human studies are done and no risk. So any drug under this category is very safe. The category B, the animal studies were done and show no risk. No risk to the animal studies. But no controlled human study are done. Or the animal risk show an adverse effects. So category B, either animal studies show no risk, but it is not proved by human studies, or it may show some adverse effects. So the drug under this category is relatively safe, like acetaminophen, as we will discuss later. Category C, animal studies are positive. The drug under this category is teratogenic or has teratogenic potential in animal studies, but no sufficient human studies are done. So the risk cannot ruled out. The drugs in this category, the risk of teratogenicity cannot ruled out. Category D, the human data show risk, but here the benefits may outweigh the risk. You must assess the benefit versus risks. If the benefit outweighs the risks, you can use. Category X, both animals or human data are positive. In this category, the risks outweigh benefits, so it is contraindicated to use the drugs under this category, like oral contraceptive pills. This table showed some drugs which are examples of the FDA pregnancy risk categories. The class 1 are the antiemetic drugs which are commonly used during pregnancy for treatment of nausea and vomiting of pregnancy or morning sickness of pregnancy. You must avoid domperidone, which is class X. The safe alternation is metoclopramide, promethazine, and dicyclomine. They are safe alternation for antiemetic drug use during pregnancy. If the female needs laxative, you can choose dietary fibers, or lactulose. Avoid senna and bisacodine. What are the analgesics which are safe during pregnancy? Paracetamol are safe. It is category B. Also, we can use ibuprofen low dose if you it is indicated. What are antibiotics which can be safe during pregnancy? We can use penicillin G, which lie under category A. We can use ampicillin, amoxicillin, cloxacillin, cephalosporin, which are under category B. Avoid tetracycline, as we have said. Avoid chloramphenicol. Avoid gentamicin. Avoid quinolones. All have various teratogenic effect to the fetus. What are the antihypertensive drug of choice in pregnant female? Number 1 is the alpha methyl dopa. This is the first drug of choice. Can be followed if no response or if the response is not sufficient by hydralazine or atenolol. Avoid ACE inhibitors, avoid diuretics, and avoid beta blockers. As antidiabetic, we can use insulin, as the insulin has large molecular weight, as we have said, and it doesn't cross the placenta. Also, as antithyroids, the only antithyroid which is safe during pregnancy is propyl thiouracil. Again, heparin as an anticoagulant is safe during pregnancy as it has large molecular weight, cannot cross the placenta, and avoid warfarin in order to avoid warfarin syndrome in the form of nasal hypoplasia, as we have said previously. Now, what are the risk communication prior to pharmacotherapeutic choice? These are the following rules must be applied due to when you prescribe a drug to a woman getting a pregnancy. Woman of reproductive age, any woman in the reproductive age must be asked prior to drug prescription whether there is undetected pregnancy, whether they are planning pregnancy or whether they already pregnant. In chronic treatment of women of reproductive age, take care of the possibility of pregnancy may occur. And also in some medical drugs or some diseases, you must reduce the effectiveness of the dose, as in anti-epileptic drugs or in any hormonal contraception. Monotherapy is preferred in pregnancy to avoid synergism between drugs and drug interactions, and also you must use the lowest effective dose. And before you prescribe a drug, you must try non-drug treatment, should be considered at first. And You must measure risk versus benefits when use any drug during pregnancy. Any drug during pregnancy must be avoided unless it is indicated. Because the disease itself may be risky and may cause complication to the fetus. So you must treat the disease with the proper choice with the most safe drugs according to the category of FDA classification and with the least effective dose, and try to use one drug better than polytherapy.